I'm Kacey Eichelberger. I am one of the maternal fetal medicine faculty here at the University of South Carolina in Greenville, and today I'm going to talk to you about one of your educational objectives for APGO, which is objective number 21 on fetal death. We will focus our discussion today on fetal death as it occurs in developed countries and not in the developing world, where the prevalence and common causes are very different. So our objectives today as we begin this talk: number one, we are going to discuss the common causes of fetal death in the United States. Number two, we are going to review symptoms suggestive of fetal death, physical findings on exam, and finally, diagnostic methods used to confirm the demise. Before we begin, I'd like to discuss how we define the term. In your APGO book, you will see the expression fetal death used. In a lot of other literature, you will see the letters I, U, F, D. Those refer to intrauterine fetal demise. And still finally, you'll often hear a family refer to their stillbirth. The term stillbirth is actually the one that is preferred by family groups and support groups, and the one that I will try to use today during the course of our lecture. All of these, however, describe the same phenomenon. It's important to remember that pregnancy loss is an extremely painful event at any gestational age, but we need to be specific in the language that we use when describing events in our documentation and to other providers to give people as much information as possible with our words. If you consider a pregnancy timeline here, traditionally there are a few different time points that divide our verbiage. We'll make this 13 weeks of gestation, we'll make this 20 weeks of gestation, and then we'll put a 28-week mark here. These are obviously not drawn to scale. Pregnancy loss that occurs during the first 13 weeks is often called an early fetal loss. Pregnancy loss that occurs after 14 weeks but before 20 weeks is frequently referred to as a mid-trimester or second trimester loss. Considered together, though, this group up through 20 weeks, we traditionally will describe these as spontaneous abortions. This is a separate conversation from the issue of fetal demise as we're going to discuss today. After 20 weeks, this time period, 20 weeks on, is when traditionally most of us will use the terms fetal death, IUFD, or stillbirth. It's important to note that different states have different interpretations of what the cutoff is, but if gestational age is known, the most common period is 20 weeks in terms of reporting stillbirth. If gestational age is not known, a birth weight of 350 grams is often used as a substitute for the 20-week mark, as it represents about the 50th percentile for birth weight at this gestational age. Within these fetal deaths or stillbirths, we will talk about early stillbirth, if it occurs through the end of the 27th week, or late stillbirth, if it occurs after 28 weeks. Again, all of this loss is extremely painful for a family, and these terms are not used in any way to diminish a loss that someone experiences early on, but rather to define for ourselves when we discuss fetal death that we can assume the person using that language is commenting on a loss at greater than 20 weeks, and when someone describes a spontaneous abortion, that usually precedes 20 weeks. So what is the frequency of spontaneous loss in the United States? The most recent estimates are about 6.2 per 1,000 births. About half of those, when you look at the numbers, will occur, those early losses, 20 to 27 weeks, and about half of these now are considered those late births. This early percentage has stayed stable over the years. We have recently experienced a decrease in the number of late stillbirths, so that number is the only number that we've been able to move recently. So what are known risk factors for stillbirth? The most prevalent risk factors are African American race, nulliparity, meaning you have not previously had a child, advanced maternal age, which is traditionally defined as 35 years of age or greater at time of anticipated delivery, and obesity. Obesity, of course, traditionally defined in pregnancy as having a pre-pregnancy BMI greater than or equal to 30. African American race is one of the areas of incredible disparity in obstetrics right now, with African American women bearing an unacceptably high burden of stillbirth. The rate for African American women, often will be defined in census as non-Hispanic Black women, is most recently reported to be 11.25 per 1,000 births. And again, in the slide previous, we discussed that the rate nationally for all women is 6 per 1,000, meaning that non-African American women by race are experiencing stillbirths much lower than 6 per 1,000, with African Americans experiencing 11.25 per 1,000. Obesity is an interesting one. The risk of stillbirth appears to increase, the risk of stillbirth, with each increase in the strata of BMI. And that holds true in large epidemiologic studies, even when we adjust for all of the potential confounders that are also associated with obesity, such as diabetes, hypertension, preeclampsia, and other medical comorbidities. So obesity in and of itself appears to be a significant risk for stillbirth. Other risk factors that we have already touched on: maternal medical disease is a huge category. The most common of those that we think about are diabetes, again increased risk with poor glycemic control, also hypertension, preeclampsia, lupus, and thrombophilias. Other risk factors: fetal growth restriction, traditionally defined as estimated fetal weight less than the 10th percentile for gestational age. Smoking, one of the few very modifiable risk factors for stillbirth. Congenital and karyotypic abnormalities, meaning that fetuses who are found to have structural malformations or birth defects, or fetuses who are found to be aneuploid, have a higher risk of having a stillbirth than those who are structurally normal and or euploid. Multiple gestations are at higher risk statistically to experience a stillbirth than singleton gestations, and that risk increases with higher order multiples. And then finally, infections, in utero infections, particularly listeria, parvovirus, B19, and then also syphilis. A final word about risk factors and or causes of stillbirth. One of the things that you will frequently hear described by parents and by providers is that the cause of fetal death or stillbirth was a cord accident. This is a tricky place to sit in terms of causality. About 30% of normal live births will be complicated by the finding of a nuchal cord, sometimes more. The finding of a nuchal cord at time of delivery after stillbirth is not enough in and of itself to prove causation. There are findings of cords that are completely void of any type of blood, very tightly wrapped around the neck, multiple nuchal cords in a tight presentation that are more suggestive of causality. But again, one has to be very deliberate in making sure that there are no other causes that would actually modify the patient's risk for recurrence of stillbirth in other pregnancies. One of our other objectives was to discuss the symptoms and diagnosis of a stillbirth, which is actually fairly straightforward. The number one presentation of patients coming in to present with a stillbirth is decreased fetal movement. Some women will say that they had experienced a change in fetal movement pattern for the week or so preceding the event, with decreased fetal movement over a period of time and then no fetal movement for, say, the prior 24 hours. However, many women will say that fetal movement was completely normal up until whatever the time period was from the event of loss to diagnosis. The initial management when someone presents is usually a physical exam and an attempt to auscultate fetal heart tones, either by Dopp tones if you are in the clinic setting, or by NST if you are in a labor and delivery triage setting. If fetal heart tones cannot be auscultated, the labor and delivery nurse will frequently call the provider to the bedside. The provider will come with an ultrasound machine and will attempt to find fetal cardiac activity. The diagnosis via ultrasound includes observing the fetus in the fetal chest with no movement of the fetal heart. We will confirm this either with color Doppler or with pulse wave or M mode. At the time of that initial ultrasound, we will frequently look at the placenta and see if we see any sonographic evidence of abruption. Of course, as you know, the ultrasound diagnosis of placental abruption is neither sensitive nor specific, and so an ultrasound alone cannot give definitive information on that event. So finally, moving into a beginning discussion about management of a recently diagnosed stillbirth. There are several things I'd like to convey to you today. The first is that you, as the provider giving this information to a patient, are frequently the person who is bridging them into the worst day or one of the worst days of their life to date. It is a horrible piece of information to convey. They will frequently know while watching you perform the ultrasound, but it's very important to use clear, concise language so that people can process what you're saying, and so there is no confusion on the diagnosis. I have had patients post-event process with me a provider whose language was not clear enough, and they were left with a period of time of wondering if their child was still alive or not. The other thing I'd like to strongly recommend is asking the family if they had named the child, and if so, calling that child by name. Again, this is almost always a desired, loved creature who is no longer with this family, and it's important to honor that and to help them begin the grieving process. So after giving the news to the family, I will frequently ask them, I will sit at the bedside, tell them how very sorry I am, and ask them if they would like a few minutes to process together some of the initial shock without me in the room, or if they'd prefer that I would stay with them. I have families who have opted for both things. If the family wants time alone, which many do, I will assure them that I will be just outside the door, that I will be there with them when they're ready to discuss again. I don't want them worrying that they will not have a provider when they're ready to discuss how to move forward. I will frequently go back in 10 to 15 minutes later to check on the family and to begin a discussion of how we need to move forward. So in thinking about beginning to plan, there are several pieces to that puzzle. One, and kind of the more medical one, is thinking about mode of delivery. In almost all scenarios, we strongly advise a mom to attempt a vaginal delivery. Women with prior incisions on their uterus can certainly try a trial of labor after cesarean, and the specifics of how we would induce that labor are beyond the purview of this lecture for medical students, but understanding that our strong desire would be to have a vaginal delivery is important to know. We will frequently recommend delivery proceed within the next day. Many women want to go ahead and be admitted and move forward, and we make every effort possible to allow that to happen. Other questions that I will ask them are to go ahead and begin considering who the support people are that they'd like to have in the room, who would be important to them to share in that birth experience. Some families just want the two partners. Some prefer friends, aunts, parents, clergy, and we try to make that as possible for them as we can in terms of space and people. Finally, we offer photos and keepsakes of their little ones. We do handprints and footprints. We give those parents a box that has all of the baby bands, has clothing that people in the community have stitched together with love to put their little one in. There are also amazing services in many communities. One that I am familiar with is called Now I Lay Me Down to Sleep, where local photographers will donate their time and talent to helping families process their loss through photography. They will come and take pictures of the family with the child and make sure that those pictures are available to a family at whatever point in the future they choose to view them. Some families won't choose to, but many, many will. And the final piece that is no fun to talk about at all, but very important to help this family process what happened and how likely is it to happen again, is a fetal evaluation, or a conversation about what should be done from a medical standpoint to try to help clarify the cause of the loss and potential recurrence risk. This topic, fetal evaluation, will be a separate Pearlcast. So we'll end this talk today with that information, and I hope that was helpful to you.